Hi, welcome to this afternoon's webinar, The Genetic Causes of Birth Defects, What We Know and What We Don't Know. My name is Vanita Leadham, and I am with the National Birth Defects Prevention Network. Today, we will welcome Dr. Sonja Rasmussen, MD, MS, who is a professor at the Department of Pediatrics, Obstetrics and Gynecology and Epidemiology at the University of Florida. Dr. Rasmussen is a professor at University of Florida in the College of Medicine and College of Public Health and Health Professions. In this role, she serves as a clinical geneticist, seeing a broad range of genetics patients, and as director of UF's Precision Health Program, which focuses on integration of genomics into clinical care. Dr. Rasmussen recently joined UF after 20 years at CDC in Atlanta. While at CDC, Dr. Rasmussen worked on the National Birth Defects Prevention Network study, NBDPS study, a large case control study to identify genetic and environmental risk factors for birth defects, and on studies to better understand the morbidity and mortality associated with genetic conditions. She also served as the Deputy Director of the Influenza Coordination Unit, responsible for CDC's pandemic influenza preparedness activities. As the Acting Director of the Office of Public Health Preparedness and Response, responsible for CDC's public health preparedness and response activities, and Editor-in-Chief of CDC's Morbidity and Mortality Weekly Report Series. Dr. Rasmussen was lead author of the paper confirming Zika virus as the cause of birth defects, published in the New England Journal of Medicine in 2016. She served in leadership roles during several CDC responses to public health emergencies, including the 2009 H1N1 influenza, H797 influenza, Middle East respiratory syndrome, and Zika virus. She also co-edited the latest CDC field epidemiology manual. And most excitingly, she works with my program here in South Carolina with the South Carolina Birth Defects Program. We're very excited to work with her and very excited to have her here on our webinar today. We thank the March of Dimes for co-sponsoring. And as a quick note of housekeeping, please enter your questions into the text during the webinar if you'd like, but we'll save all questions to the end. Thank you so much for joining us today, and welcome, Dr. Rasmussen.
Great. Thank you so much, Vanita. I'm excited to be here and to be talking about something else other than COVID right now. As Vanita said, I'm going to be talking about the genetic causes of birth defects, what we know and what we don't know. And I am appreciative to the National Birth Defects Prevention Network and to the March of Dimes for sponsoring the webinar, and also for the South Carolina Birth Defects Program for getting me involved in birth defects again. So thank you, Vanita. So I'm going to just give you an overview of what I'm going to talk about. First, I'm going to talk about what do we know about causes of birth defects in general, how often do they occur. It's surprising that we have fairly limited information about this. I'm going to talk about the types of genetic causes, so chromosome abnormalities, single gene disorders, and then that multifactorial, that kind of group that we don't understand very well. And then I'm going to give some case examples of different types of relatively common birth defects for which I'm going to give you some examples of causes. To give you some sense of the genetic causes, I am going to have to give you a brief primer on genetic testing, but I'll try to keep that to a minimum. So what are the causes of birth defects? As I said, there are genetic factors. And the main categories that those fall into are chromosome abnormalities and single gene disorders. There's non-genetic factors, and of course, we're all trying to understand those better because those are things that we can change. We can try to be sure that a woman gets folic acid during her pregnancy so that she doesn't have a baby with spina bifida. We know certain medications increase the risk of birth defects. We know there's maternal conditions like diabetes or obesity that increase risk of birth defects. Infections, of course, and you heard about Zika, CMV, toxoplasmosis, and of course the original one of rubella, and then environmental exposures like alcohol and other environmental exposures like mercury. Then there's this big category of multifactorial, and this is really a combination of multiple genes and environmental factors. And I think this is something that we're going to learn more about as time goes on. Human disease in general and birth defects, I think we're going to learn that more are due to multifactorial origin, but I'm hoping that we're going to be able to understand what those multiple genes are and what those environmental factors are. So I'm going to start with this paper by one of my mentors, Dr. Lou Holmes, and his colleagues in Boston, and it was published in Birth Defects Research in 2018. And it used data from the active malformation surveillance program at the Brigham and Women's Hospital. I had the opportunity to work with Lou on this project back in, well, a whole long time ago, when I was still a medical student in 1990. And this is a very nice program that's been collected data for a lot of years. It looked at the presence of malformations diagnosed in the first 5 days of life among almost 300,000 births over a 41-year period. They identified about 7,000 infants and fetuses with one or more birth defects, and that was about 2.4%. Now, as a reminder that it's in the first 5 days of life, so that compares to, for example, the Metropolitan Atlanta Congenital Defects Program or some of the other surveillance programs that have a higher rate, maybe more in the range of 3%. And then they classified the etiology as best they could into Mendelian or single gene disorders, chromosome abnormalities, multifactorial, and other types. And this is the results. Here you can see on the left side, you can see the actual table that was in the paper. And I'm going to focus on these data, not the earlier data that ended in 1985, but the total from 1972. They had a little bit of a gap in there, but then until 2012. And here you can see, I think the biggest story here is how many times we really just don't have an idea of what caused a baby's birth defects. You can see more than half of the time, we can't tell families what caused their baby's birth defect. But, and here you can see this multifactorial group. The multifactorial group is really important too, because for those families, we know that they have an increased risk in future pregnancies, a small increased risk, but yet an increased risk. But in most cases, we don't understand what those genes and what those environmental factors are. Then I'm going to talk here. So this study, Dr. Holmes' project includes babies with postaxial polydactyly, when you have an extra little pinky finger, which I know some programs don't include, and that's in the orange here. But I'm going to have you focus here on this little blue slice and the gray slice. The gray is the ones with chromosome abnormalities, and the blue is with single gene disorders. Now, keep in mind, this was a big number of years. And so in recent years, we have more information about chromosome abnormalities. And so if we look at a single time, say we looked just in the last 5 years, I think we would see that chromosome abnormality rate be higher. And I think we would see single gene disorders be higher too. But I think this study is helpful in that it emphasizes how much we don't know about causes and how important research into birth defects is. So there are some study limitations. First, it was limited to diagnoses made in the first 5 days of life. The diagnostic studies, chromosome microarray and exome sequencing, for example, that I'm going to talk to you about, that are really the exciting area and are allowing us to make a lot of more diagnoses of genetic conditions than we could in the past, that was used in only a few infants. The study was over 41 years, which is, a lot of positives, but it also, the negative is that included times where we didn't, we were using very limited genetic analyses. And then another thing is about 20% of the malformations were actually in pregnancy terminations, which complicated the diagnostic assessment. So I want to just begin, I'm a geneticist, so I think this is really, really important, but why is making a clinical genetic diagnosis important? And there's a lot of reasons. One is for families, they have a baby with a birth defect. One of the questions they want to know is, why did this happen to me? And is it going to happen again in a future pregnancy? We really need to figure out if there's a genetic diagnosis to be able to give them that information. What about what other organ systems are involved? And I'm going to show you an example of a case that actually I have seen that where by identifying what the genetic diagnosis was, it made us look for other things that we wouldn't have actually probably recognized right away, and that helped the child's health. So are there other defects that need to be looked at? Are there, for example, a child that has a cleft lip? If it's a condition that also kids have heart defects, then you need to be sure that you do an echocardiogram. So it helps doctors to think about what other tests need to be done. It also helps to assess the risk for neurodevelopmental delays for newborns and infants, and that can help to make sure that child gets referred for early intervention services early so that they have the best chance at reaching their full potential. And then finally, it provides more accurate prognosis. Is this a condition that the child is going to do well and that we know that children are going to grow up, or is this a condition that may have a limited type of lifespan? So I want to just start with talking about genetic studies and how much genetics has changed as far as the studies. I started in genetics as a genetic counselor in genetic counseling school in 1981. I finished medical school in 1990. I finished my genetics residency in 1996. Huge changes in that time in what we know about genetic causes because of improvements in genetic testing. Really, in those days when I was a genetic counselor, medical student, and even a fellow, really all we had was cytogenetics and some limited information about single gene disorders, but not really good testing for them in general. So what that means, though, is that there's a huge increase in the number of genetic tests. And this is a paper that was published by Catherine Phillips in 2018. You can see the huge number of genetic tests on the market and how rapidly they're increasing. And as of 2017, she reported that there were 75,000 genetic tests currently on the market with more than 10,000 unique test types, and 10 more genetic tests were being added each day. So it means, as a clinical geneticist, as a genetic counselor, every time I see a patient, I have to think, is there a new test that I should be thinking about for this child? It really is rather overwhelming, but exciting at the same time. So what are the types of genetic testing in general? Because I'm going to talk about a couple of these and then some I'm not going to address at all. First of all, most of what we're going to be talking about is diagnostic testing, the kind of testing that you do when you're a clinician, you're looking at a child, you're trying to figure out what the cause is. I'm trying to come to a diagnosis. So that's diagnostic testing. There's also prenatal testing, and that's done by OBGYNs, maternal fetal medicine specialists. That prenatal testing can be screening or it can be diagnostic testing. And it's really, really important to figure out which one you're looking at, whether it's prenatal screening. We've, of course, known about prenatal screening. We were doing AFP screening even back in 1981 when I started in genetics as a counselor. Then looking at that knuckle translucency. And then now there's non-invasive prenatal screening where you actually draw the mom's blood and you can look at some of the fetal cells. And I'm going to be talking about that because I think it comes up pretty frequently. I know some of the attendees are abstractors, and so that comes up there. Then there's prenatal diagnostic testing, and you can do tests that you can do on an infant, you can do during pregnancy, but you've got to get access to those samples. And the way to do that is either by amniocentesis or chorionic villus sampling. Then there's these other types of testing that I'm not really going to be talking about, but I just want to mention them. The predictive testing for cancer predisposition, for example, BRCA1 and BRCA2, carrier testing or heterozygote testing, for example, Tay-Sachs testing for people of Ashkenazi Jewish background, cystic fibrosis, sickle cell disease. And then newborn screening is actually a really important area of genetic testing. And we all know, those of us in public health know that every baby that's born has the opportunity to have this newborn screening done. A lot of those are genetic tests, and to determine whether the baby has something that if they get treatment for, they can prevent severe outcomes. So I'm going to divide, for the diagnostic testing, I'm going to divide it into two categories: to identify chromosome abnormalities and then to identify single gene disorders. To identify chromosome abnormalities, there's really primarily a karyotype and a chromosome microarray. And then single gene disorders, you can, if you know what the kid has, you think you know what the child has, you can send just looking for a single gene. These days, we don't always have to be that smart anymore. We can do a multi-gene panel. We can say, well, I know this child has developmental delay or has autism, and I can send a panel of genes. Or I can do exome sequencing, or I can do genome sequencing. And I'm going to talk about all of those. The exome is really focusing on the coding regions, the exons of the genes, where the genome sequencing is really sequencing all of the genome. So I just want to tell you about how we're going from big changes to smaller changes. So this is for routine chromosomes to looking at chromosome microarrays. We're going from 10 million to 0.01 million. So, or the same thing here, a picture here, you can see how with a karyotype, we would be looking for maybe that little tiny piece of chromosome 5 missing or extra, where with chromosome microarrays, we can see even a smaller piece than maybe could be seen under a microscope. And then this is the gene analysis where we're looking at DNA sequencing. Previously, we were doing something called Sanger sequencing, but with this next generation sequencing or massively parallel sequencing, we can do it a lot faster and a lot cheaper. So I'm going to start with chromosomes, chromosome analysis, karyotype. This is something that still has an important role in working up certain kids. It's looking at an individual's collection of chromosomes. It's trying to look at abnormal numbers or structures of chromosomes. So in some cases, for example, I'm going to show you in a minute, you can have a whole extra chromosome 21. That means a child has Down syndrome. Or you can have a little tiny piece of a chromosome missing. And you can see if you had a little tiny piece missing here, you might not be able to see it on this karyotype. In the old days, we used to try to stretch those chromosomes out. If you caught them at a certain time in their division, they would be stretched out more and you'd had a better chance. If you had a lot better eye than I ever did, you could see the piece missing. But the limit of resolution, you have to have 3 to 5 megabases missing, lots and lots of those letters missing to be able to see that on a karyotype. Then there's a chromosome microarray. This allows us to see much smaller areas of loss or of gain of chromosome material, from 1 kilobase, 1,000 bases to many megabases. And of course, one of the people I work with says this is one of those times when it's location, location, location. We can have areas where you have an extra piece or a missing piece of chromosome that doesn't really matter because it doesn't have any genes in that area. But depending on the size or the genomic location of that copy number variant, that extra or missing, sounds like my Amazon packages here. So the deletion or duplication can include 0, 1, or many genes. And it's also important to look at with these results that the variants can be benign, they can be pathogenic. That means that they can be known to be associated with problems for the child, or they can be of uncertain significance. And this is one of the things that I think is one of the really hard things about genetics these days, is dealing with the variants of uncertain significance, which we see both on chromosome microarray and on some of the other tests that we do. So just when do you do a karyotype? When do you do a chromosome microarray? Chromosome microarray is more sensitive at detecting small areas of missing or extra material. And so oftentimes you are going to focus on you doing a chromosome microarray. It can detect copy number variants, little pieces extra or missing as small as 100 kilobases or as small as a single exon in a gene. And it is really thought to be the first line test for persons with developmental delay, intellectual disability, multiple congenital anomalies, and or autism spectrum disorder. Typically insurance pays for it. This is one of the issues with genetic studies, is we still struggle with getting insurance to pay for some of this testing, and this is typically paid for. And when I think about the times when I used to see patients, when I was at CDC, I saw patients at Emory for a while. The yield of a karyotype for those kids is about 3% of the time you get a diagnosis, where the yield with the chromosome microarray is much better, about 15 to 20%. So your chances of finding something are a lot higher with a chromosome microarray. So then what about those? So I'm just going to go back here. There are times, though, that a karyotype is still needed. And that's because we know that there's extra missing material, but we don't know how it's arranged. And for example, if you have a child with Down syndrome, I'm going to give you an example of this later. You need to know, is that 3 separate chromosome 21s, or is one of the chromosomes attached to another chromosome, what's called a translocation? That information is absolutely necessary to know not if the child has Down syndrome or not. The 3 sets of chromosome 21s tells you that, but to tell the family whether they're going to have another baby with Down syndrome, they could have up to 100% risk of having another baby with Down syndrome, depending on what that karyotype shows. So if it's a child with Down syndrome, you really need to have still a karyotype. So single gene test, this is when you are pretty sure that the child has a single gene disorder and you know what that is. And then you test for that single gene. And you can either test, these days, I think most of the time people are doing gene sequencing or and deletion duplication testing. In the old days, maybe more common mutation panels. Then there's these multi-gene panels, and we are using a lot of these in clinical genetics. You know, if you have a child with autism and developmental delay, there are a number of genes that can be tested using this massively parallel sequencing, the next generation sequencing. And it's cheaper and faster than doing it gene by gene by gene by gene. If you think of maybe there's hundreds of genes, you wouldn't want to do that one by one. Although I have to tell you, sometimes I have to really point that out in letters to the insurance company that wants me to be able to do just single gene testing. Many disorders are genetically heterogeneous. They look exactly the same with one gene or the other. And of course, so it's really important to be able to use this multi-gene testing. And I've talked to you already about intellectual disability, autism. There's also panels for hearing loss, for retinitis pigmentosa, for infantile seizures, for congenital heart defects, and so on. And exome sequencing, which looks at the exons. So exons are the segment of DNA that's containing information that codes for the protein. It's the part that you know, remember that there are exons and introns. The introns are the intervening sequences that get snipped out and they don't end up coding. So this is looking at just the part that ends up coding going into a protein. Exons only make up about 1% of the human genome. The rest of it is non-coding. 1 to 2%. And all exomes in a genome are known as the exome. That's where the word comes from. So the sequence of the exons is called exome sequencing, or some people still call it whole exome sequencing. I think we're trying to move towards exome sequencing. And that's something you might say, well, why don't you just do that? Why would you do any of those multi-gene panels? Well, one of the things when you do exome sequencing, sometimes you find things that you didn't really want to know. For example, you might find out about changes in genes that don't have anything to do with the, for example, you're seeing a child with autism and developmental disability, and then you find out that the child has an increased risk for breast cancer, has a mutation in the breast cancer gene. Of course, that information might be helpful to the child later on to know that, but typically we don't do that kind of testing in children. And so that is something that complicates the exome sequencing testing. And then you can do genome sequencing. Genome sequencing, I'm not going to talk about a lot because that is really primarily done right now more as a research study. But I think in the next few years, we'll be doing more of it. So here I've talked already about prenatal screening versus diagnostic testing. It's important that screening is screening. It's like screening that you do for prostate cancer, where you look at a prostate specific antigen and you see the PSA is high and you say this person's at increased risk of having prostate cancer, or a mammogram that's a screening to look for breast cancer. Doesn't mean that woman has breast cancer. She has something on there that suggests that she might have breast cancer. The screening versus diagnostic testing is really important in prenatal, and especially for those of you that are doing abstracting of charts. So I'm going to talk about non-invasive prenatal screening because I have seen this is really being widely used now. It first became available in 2011. I remember when in genetics, when people first started talking about this, it seemed too good to be true. You could know information about the fetus without doing an amniocentesis or a chorionic villus sampling that would put the fetus potentially at risk. And so it is really an exciting thing. In 2012, ACOG, the American College of OBGYN, approved its use for women that had increased risk. And then in 2016, they said, you know, women should have the opportunity. This test is available. They can be educated about it, about the pros and cons of the testing, and make an informed decision deciding if they want to have the screening method done or not. So it's also known as cell-free fetal DNA screening. It's done on drawing blood from the mom about 10 weeks gestation or later. The pregnant woman's blood contains DNA from her pregnancy, from her placenta. And then you can look at, does the fetus have trisomy 21, trisomy 18, trisomy 13? Some labs can also report other kinds of abnormalities, can look at sex. That will allow you the opportunity to look at sex chromosome abnormalities and other things. You need to look at what the test that was done and what it shows and what it doesn't show. So here you can see, this is from a JAMA paper a couple years ago. So basically, this is the placenta, and the placenta releases fetal DNA fragments from the placenta into the maternal circulation, and that's what you're testing. So here, there I go again. Okay, so here you're looking at the DNA. You have to be able to tell the mom from the fetus, and then you can say if there's a pregnancy with trisomy 21, if there's 3, for example, sequences, triplication of sequences of chromosome 21. So now I'm just going to start going through some cases, because I always think it's more interesting to hear about cases. I hope you guys agree. This is a full-term infant born to a 26-year-old mother. The prenatal ultrasound and echocardiogram showed an atrioventricular canal, or an AV canal, or an AVSD. Non-invasive prenatal screening, that NIPS study done at 10 weeks of pregnancy, was positive for Down syndrome, and the mom didn't want to have any further testing done. So I think this is really, I'm trying to do this to illustrate the importance of prenatal screening, that this is screening. So you read if you go on the lab's websites, they talk about how accurate this information it is. It does have high sensitivity. If the fetus has Down syndrome, you have a 99.1% chance of identifying it. The specificity is high, 99.9, but remember your epidemiology classes where they told you that positive predictive value really depends on how likely it was for the person to have Down syndrome in the first place. How likely was it for this mom at age 26 to have a fetus with Down syndrome? And for a 26-year-old, Down syndrome is, the risk of it is pretty low. So the positive predictive value, the chance that the baby actually has Down syndrome at that time is 59%. So maternal age at 26, the positive predictive value is 59% for this test. So you see, it's very different if the mom is older. If the mom's 40, she starts with a much higher risk for trisomy 21 in the first place, then her positive predictive value is higher, or 95%. Now, we knew this baby had an AV canal. That's a fairly classic defect in a child with Down syndrome. So I think you probably would have given this mom a higher risk than that 59%. But it's important to note that just because there's non-invasive prenatal screening that says Down syndrome, what it means is there's a risk for Down syndrome. It doesn't mean that the child has Down syndrome. The other thing, as a reminder, you really need a karyotype. So because we want to know what kind of Down syndrome it is. So here the child is born, has features of Down syndrome, and here's the CDC figure, one of the figures that was drawn of child with Down syndrome, and so you can see some of those features. And here's a karyotype. This is actually a karyotype that is from a book, but you can see the 3 separate chromosome 21s here. That means his family for future pregnancies is at a low risk, about 1 to 2% of having 1% to have another child with Down syndrome. Now, if instead of seeing the 3 chromosome 21s, we saw 2 and then 1 attached to chromosome 14, or if we'd seen even more so, and I saw a child in clinic about a week ago that had 2 chromosome 21s stuck together, then it was really essential for me to look at the parents' chromosomes, because if the parents, if one of them had that translocation where the 2 21s were stuck together, they would have a chance of 100% chance of having another child with Down syndrome. So here are just for abstractors, this is why having that karyotype is so important. If you don't have the karyotype, if you have a chromosome microarray, you can say this is Down syndrome unspecified, but you need the karyotype to say, is this trisomy 21, meiotic non-disjunction? Is it mosaicism or is it a translocation? And that's really important for coding and even more important for the family for the recurrence risk information. So case 2, this is a full-term infant born to a 40-year-old mother. You do family history and the dad also has a cleft lip, and the prenatal ultrasound showed a cleft lip and palate. The non-invasive prenatal screening done at 11 weeks of pregnancy was normal, and mom declines further testing. And here's some pictures from CDC of cleft lip and cleft palate. And this is a picture that Jeff Murray kindly lent to me. The physical exam shows lip pits, and these lip pits really tell us that this is not just garden variety, run-of-the-mill cleft lip and palate. It tells us to be thinking about this condition called van der Waals syndrome, which is a single gene disorder due to pathogenic variants in a gene called IRF6. So it really tells us to look at the IRF6 gene. You're not going to see that on a karyotype. You're not going to see that on a chromosome microarray. You're going to need to do molecular genetics testing of that gene. And then the recurrence risk to that family, given that we heard the dad had a cleft 2, would be a 50% risk of passing on van der Waals to future children. So this is a next child. It's a 6-day-old infant with a cardiac murmur. They do an echocardiogram and it shows a tetralogy of Fallot. The family had no prenatal care, so you don't have any testing from during the pregnancy. The family history is negative, and genetics is consulted, and genetics notes that there are some mild dysmorphic features, but not something that is immediately recognized. So a chromosome microarray is sent. That would be typically the first test that would be sent, and it shows a 22q11.2 deletion. This previously was called DeGeorge, or sometimes called velocardiofacial syndrome. And what this tells us, first of all, it tells us that we need to look at the parents, because sometimes parents who look pretty normal can have the deletion too, and that puts them at an increased risk for future pregnancies. But it also tells us there's a number of other conditions that are seen in kids with 22q deletions. And so we've got to think about those. We had a kid recently, a baby recently that was diagnosed with 22q deletion. And then no one had noticed the baby had some issues with feeding, but no one had gotten a good enough look back, and we were able to see that the child had a cleft of the soft palate that hadn't previously been recognized. Calcium can be tested. You can have hypocalcemia. Renal ultrasound should be done, and this baby showed a renal problem. And these are some of the physical features. I think you can see that maybe this child has some minor dysmorphic features, but typically not something like Down syndrome, where I think everybody recognizes this condition. And this is just a study that Lorenzo Botto and a group of us from CDC and from Children's Hospital of Atlanta did several years ago. And I just want to show this, that there are some of these heart defects that really have a pretty significant contribution to 22q11.2 deletion. If you look at interrupted aortic arch type B, about half of those babies had 22q deletion. Truncus arteriosus, about 19%. And then here's the case that I was telling you about, tetralogy of Fallot, about 12%. There's some others that are lower rates. You can see hypoplastic left heart, it's not very common at all. And among all babies with heart defects, it's about 1.5%. So now the last case is a 34-year-old mother who has diabetes. She has type 2 diabetes. A prenatal ultrasound at 16 weeks shows spina bifida, and the baby is born at term. Baby is non-dysmorphic, no other abnormal findings. A chromosome microarray is sent, and the baby has normal results. And this is spina bifida. The most common cause of spina bifida is multifactorial etiology, and that's a combination, and we all know about the importance of folic acid in spina bifida. So it's a combination of nutritional factors, genetic factors, and other environmental factors, like diabetes, like certain medications. And but we don't completely understand those genetic factors. We have some studies that have told us about those, but we don't completely understand those yet. We know that there are gene environment interactions there, though, that some of the genes that seem to be important are ones that are associated with how folate is metabolized. And just for this case, it's important to know that multifactorial etiology, because that's a child that you would want the mom in a future pregnancy to get a higher dose of folic acid, starting 1 month before becoming pregnant and during the first 3 months of pregnancy. Before that happened, before we were able to recommend that people got folic acid to prevent recurrence, the high dose folic acid to prevent recurrence, the recurrence risk was 2 to 5%, and that has been substantially decreased when women get folic acid in future pregnancies, get supplementation in future pregnancies. So I just want to talk a little bit about rapid exome sequencing, because this is becoming more and more common at lots of hospitals across the United States, and some of you might work in some of those hospitals. This has been shown to have a high diagnostic yield and result in changes in clinical management. It's usually done right now in kids that are critically ill and where there's a suspected single gene or monogenic disorder. And this is a paper that was just published recently. There's been a number of these papers, and I just chose this one because it was a recent one. So here you can see this study included 131 infants and children that were either in the neonatal intensive care unit or in the pediatric intensive care unit that were critically ill. That they were excluded for different reasons. They ended up with 108 that underwent ultra rapid exome sequencing. They can do this exome sequencing in 24 to 48 hours. Obviously you have to have a lab that's ready to take the specimens and jump on them right away. Of these, 51%, so 55 out of 108, had a molecular diagnosis made, and 42 out of that 108, or 39%, changed the clinical management. Now, there's a number of different studies. Of course, it all depends on how what cases are included in the study in the first place. And so sometimes those numbers are higher, sometimes they're lower. But you can see that this really could make a difference, especially in these kids that have critical illness at the time of their evaluation in either the NICU or the PICU. And here is a table, and I just picked one of these here, one of the babies that had birth defects. The baby had severe hydrops and joint contractures, and they were able to identify a condition, lethal congenital contracture syndrome 11. No one would have come up with that diagnosis without doing a study, without doing a laboratory study, because these different types of congenital contracture syndrome look similar, and they look similar to some other conditions as well. This allowed them to direct the care towards palliative care for the family within 24 hours of getting the results. So this is a paper written by Stephen Kingsmore, who's at Rady Children's Hospital in San Diego. He's been doing this rapid exome sequencing and been one of the leads in this area for several years. And this is a paper he wrote, you can see hot off the press, November 2020 in Journal of Pediatrics. Is rapid exome sequencing standard of care in the neonatal and pediatric intensive care units? And he argues that we need to be thinking about that rapid exome sequencing for kids where they're critically ill, to try to come up with a diagnosis and, if possible, change care. So I am going to finish up, and then I know that Diana has some questions that people sent in, and I can see that looks like there's some other questions that have come in. But just to summarize, birth defects often have a genetic cause. It can be they can be due to chromosome abnormality, a single gene condition, or multifactorial, where in most of the time we don't really understand what those genetic factors are. As we learn more and genetic testing improves, we're gonna identify more genetic causes. And it's incredible to me in the years since 1981, when I started in genetics, how much more we know now than we did then. And it's incredible. I think it's an advantage, a huge advantage, because we can tell families the likelihood of it happening again. We can help give a better prognosis for their child, and we can take better care of their child now than we could in the past. We can tell them that we need to look for certain other conditions, and rather than waiting for that to be identified when the child gets sick with a heart problem or a kidney problem. And then the other thing is information on genetic causes is really essential, not only for appropriate patient care, but also for the counseling of family regarding their recurrence risk. And of course, families, when they have a child with a problem, they do want to know for a future child what my chances are of this happening again. So I'm happy to answer any questions.
Thank you so much, Dr. Rasmussen, for a great and informative presentation. We do have a few questions coming in. Feel free to keep chatting them in and we'll track them as they come. I'm kind of grouping similar questions. We'll start with a fun one. What do you view as the iconic birth defect for which we have little information on etiology?
Yeah, I saw this question before, and this is a tough question. So the person who asked it, this is a hard question. I think that we don't know a lot about things that are more rare, but because we just don't have enough cases to be able to do a lot of studies on them. But one of the defects that I think is really that we just don't have enough information on is gastroschisis. Gastroschisis seems to go up and down and seems to be almost occurring in outbreaks and seems to be among younger women, and lots of times doesn't have a chromosome abnormality. Most of the time doesn't have chromosome abnormality, doesn't have single gene conditions. So, that would be, and it's also a defect I'm really interested in. So I'm sure there's others too, but I'm going to choose that one for today. I feel like we don't know very much about gastroschisis, and it's really a challenging defect.
Thank you. How do we integrate genetic and social science research to learn more about what we don't know and apply it?
Yeah, I think the social science research is so important, especially when we start understanding causes of birth defects. When we know about, for example, Accutane as causing severe birth defects, the acne medication causing severe birth defects. How do we make sure that women know that when they're taking Accutane, that if they get pregnant, they can have a baby with a severe birth defect? And so I feel like that's one of the important areas. I think, I don't think this has been used very much, but I think it might be interesting to maybe do some focus groups and understand what women think about birth defects causes. What do they think has caused their baby's birth defects? And certainly we know examples in the past where moms' proposals have ended up, for example, rubella. The story about rubella is that it was moms in the waiting room of the ophthalmologist that came up with knowing that they all had a rash-like illness, they all had rubella during their pregnancy. So I think that might be interesting too, but that's sort of speculation. But I think the big thing is trying to make sure that for what we do know the causes, that women get that information and are able to act on it.
Okay. Next one, are there genetic links between birth defects and subsequent development of cancer?
That is an area that is of great interest to me and several of my colleagues. It does appear that children with birth defects do have an increased risk, certain types of birth defects do have an increased risk of cancer. And of course, it's incredibly important for us to understand the reason why, in part because we want to know which of those kids do we need to screen. So we know kids actually, for example, with certain genetic disorders like Beckwith-Wiedemann syndrome is a condition that's associated with omphalocele. Those kids are at increased risk of liver tumors, hepatoblastoma, and of Wilms tumors of the kidney. And it's those kids, if we can identify the Beckwith-Wiedemann syndrome, then we can do ultrasounds, do AFPs on those kids and not prevent them from getting cancer, but know early on. And so at a time when it's more treatable. I think the question is, for the ones that we don't identify a syndrome, is there a gene that's important, or could it be a common environmental cause that increased the risk of both the birth defect and the cancer? And I think we don't know the answer to that right now, and it's really critical research to be done in the future. So great question, thanks.
Why does CDC exclude select defects with genetic etiologies in BD steps?
Yeah, so when you're doing epidemiologic studies, you'd like to have the groups as homogeneous as possible. If you have cases in there that maybe have a different pathogenesis, and I think, you know, some people have proposed that you shouldn't do that. Some people have said, well, gosh, if you looked at kids with Down syndrome who have a heart defect versus don't have a heart defect, maybe you could identify what the causes of heart defects are in Down syndrome. Other people say, well, the cause, we know the cause, it was the Down syndrome. It was related to that extra chromosome 21. And so that's not a case you should be looking at other environmental factors. I think that is, you know, I was involved in some of those early decisions for the National Birth Defects Prevention Study. And I think that's what we were thinking then, is that we wanted as clean of group, as homogeneous a group as possible to maximize the chances of identifying risk factors.
Which chromosomal genetic defects have a significant difference in incident rates by race or ethnicity?
For chromosome or genetic birth defects, I'm not aware that there are a lot that have big differences. You've seen, for example, spina bifida can be more frequent among women of Hispanic background, and some of that may be differences in getting amounts of folic acid, but that's not a genetic cause, that's a multifactorial cause. So for chromosome and genetic birth defects, I think sometimes we see differences. For example, we see differences in rates of Down syndrome because there may be a different rate in pregnancy termination among different race ethnicity. Otherwise, I can't think of any differences in incidence rates right off the top of my head. So.
Okay. Do you know of any researchers who are using epigenetic analysis to study association or potential causes of birth defects, such as Vater-Vactyl, you know, known syndromes with genetic associations that are not yet known?
Yeah, I think there are people that are doing that. I couldn't tell you off the top of my head, but I think really there are a number of areas of research that are being proposed, because as I told you, there's so many kids with birth defects that we don't know the causes, that I think people are looking at more things like epigenetics and other types of causes that just trying to get to the bottom of this. So.
Okay. Can you think of a good example of a multifactorial cause of a birth defect where a direct interaction of genetic abnormality with other factors can lead to a specific defect?
Yeah, you know, we used to try, you know, when I was at CDC, we tried to look at some of the people that had not taking folate and having different genes for folate metabolizers. It never was a completely convincing story to me. And it's always hard to know really whether the woman was getting folic acid or not. And then looking at the genes, someone else on the call might have a better, more recent data on that. I think that's the thing that would be kind of a nice story if we could put it all together. And certainly I think there are some researchers that feel that that's true. But otherwise, I don't know of other ones. And I was never completely convinced in the data that I've seen in the past. So.
Okay. Do you have any information about the new information regarding children born with cerebral palsy, where that's considered possibly genetic, findings of linked genes or genes that kind of control how the brain circuits being wired during early development? And some genetic
there are a number of genes being identified. I didn't focus on that because cerebral palsy is more of a developmental disability than it is a birth defect. It is something we as clinicians are starting to send panels of genes for cerebral palsy. And actually oftentimes families come to me after the neurologists have sent panels of genes, and they get results that they are asking for our help in interpreting, especially when they get variants of uncertain significance. They have sent families to us to say, do you think this is what really caused the cerebral palsy, or is this a variant of uncertain significance? Doesn't mean anything at all. So
And another kind of similar, not necessarily a birth defect question, but leading to that, do you see low birth weight with infant death as a possible birth defect with genetic causes?
You know, I think there is a lot of overlap between low birth weight and genetic disorders. And I think whenever you see a child that has low birth weight, it's important to look especially carefully to see if there is something else going on, if there is a genetic condition. We know not infrequently there is for kids that have either low birth weight or failure to thrive. But sometimes it's something totally separate. It's not genetic at all. It's something that happened during the pregnancy where the mom maybe wasn't getting sufficient nutrition or the placenta wasn't working right. So it is something to always, when you see a child of low birth weight, to think about the possibility of a genetic cause. But usually you need something else to sort of push you over the edge to start doing genetics testing. Oh, this says with infant death would certainly increase your suspicion. So.
Okay, we have just a couple more questions. So if there are participants with questions, please feel free to type them in the chat. We have plenty of time with Dr. Rasmussen. Next one is, what do you think is the way forward to solve many of the birth defects with unknown etiologies? What's kind of the map for the future?
Yeah, I do think we need to continue to do the careful sort of epidemiologic studies. And I know it seems that they take a long time and they take a lot of money, but the National Birth Defects Prevention Study, BD steps, those are important ways to look at environmental factors. It's important to also continue to do those genetic studies. And now that we have better genetic tools, we have tools that we didn't have in the past. It's really important to be able to use those tools. I do think, trying to look at those gene environment interactions is going to be really important, but it takes huge numbers. That's what sort of my conclusion was of the work that we did in the National Birth Defects Prevention Study when we tried to look at genetic factors and environmental factors. Is once you're looking at a child with a certain birth defect, and then you're looking at, okay, the mom has to have been exposed to this or not exposed to this, and then she has to have this genetic variant or not, you're getting into, you've taken what look like big numbers and ended up being pretty small numbers. And so then it's harder to see the effects. That's why we need funding to be able to look at bigger numbers to be able to see these effects.
So this may fall under the funding part as well, but kind of following up on that infant death, looking or recognizing that fetal death is often related to birth defects, or, they each have a higher rate when they're combined. Do you foresee it being a possibility of actually doing genetic testing or more testing on stillborns to trace some of those genetic factors and or likelihood of syndromes or birth defects? Yes.
And there are some recommendations already that some geneticists have put together about what kinds of studies should be done on a stillbirth, on a baby that's been stillborn. There are so I am now working with pediatrics, but I'm also working with OBGYN at University of Florida. And when we see fetuses that have defects, and sometimes we can see it's a fetus that is likely to eventually be a stillborn, we try to be thinking right ahead of what kinds of studies need to be done, because you need to be able to get those studies off quickly, because that's the only way the family is going to know what their recurrence risk is in the future. So I think we need more studies, but also clinically, I think it's starting to be used clinically as well. So.
You talked a little bit about the folic acid connection, obviously, to spina bifida and the relation between genetics and the medication. What about looking at kind of the opposite side, medications that are actually known teratogens and related to the genetic susceptibility?
Yeah, I think that's something we really need to understand too. It'll help us understand what the mechanism of the teratogenicity is, what is it? Because maybe the woman could stay on the medication and there would be a way to interrupt that teratogenic effect, or maybe some women would be at lower risk based on their genetic findings. Certainly there were some studies many years ago looking at this for anticonvulsant medications. that some women were at increased risk and some women were at lower risk. So I think that is going to be really important to look at as well.
And last question I currently have, unless new ones come in, can you talk a little bit about the male-female survival rate among conditions with genetic defects?
Yeah, in general, it's an interesting thing. We all know that women live longer than men. That is true for babies. That's true for babies with prematurity, for example. Females at the same gestational age tend to live longer. I'm not sure we understand exactly why that is, but there does seem to be a difference for some defects as well. And some chromosome abnormalities, for example, trisomy 13, 18.
Okay, so we'll give it a couple of minutes for additional questions to come in. On behalf of NBDPN, March of Dimes, I want to thank you so much, Dr. Rasmussen, for this wonderful, informative talk again. The webinar will be available on the NBDPN site, nbdpn.org, for members. If participants have questions about becoming a member, you can also get that information on nbdpn.org. Dr. Rasmussen, did you want to share contact information if there's additional questions? Or
yes,
I think you have one more slide.
Yes, I want to acknowledge Jeff Murray and Jaime Frias. I used some of their pictures for this presentation. And there is my contact information if anybody wants to reach out. It's the same first 4 letters that I had at CDC for those 20 years, and then it's just ufl.edu.
It's hard to break habits, right?
I know. They did that. I didn't even do it, but I think they just knew how forgetful I was. So.
I love it. You can also submit questions online to Vanita Leadham, who sent out a lot of the information regarding this webinar. We do have future webinars planned, one for January on Birth Defects Prevention Month activities, and some ideas for that. And again, we thank all the participants for joining on behalf of NBDPN, and also thanking NBDPN and March of Dimes for co-hosting. Thank you, Vanita Leadham, for leading a lot of this. And thank you again, Dr. Rasmussen. This was a wonderful presentation, and we will definitely follow up with questions. A lot of thank yous and a lot of positive compliments coming in. Excellent as always, great topic, very informative talk, so a lot of good feedback. Again, we thank all of the participants. Please feel free to reach out with questions. nbdpn.org for more information. And we appreciate everybody participating, and again, mostly Dr. Rasmussen for such a wonderful presentation.
Thanks so much for all signing in. Now back to COVID. Thanks, you guys.
Thank you.
Bye-bye.